Hey guys, thank you for having us. I'm going to kick this off and introduce Eric, but wanted to start by introducing myself. My name is Dennis McClellan, and I am with Sterling Seacrest Pritchard. We are the insurance broker for South and Indies malpractice and a number of other policies, but the malpractice is what we're going to focus on today. We have brought Eric Kleckler in, who is patient safety in the patient safety department for the doctor's company, which is the carrier that South and Indies malpractice is with. So, what he's going to go through is just a myriad of issues that you guys interact with day to day. Nothing groundbreaking, but it's just a good reminder to, a good way to keep these things top of mind. So, just wanted to kind of walk through this stuff with you. Obviously, if you guys have any questions, and I'm sure Eric would say this, feel free to interact with Eric and ask questions as things come up. But without further ado, I'll introduce Eric and let him present.
Thanks everyone for having me. If you have a question in the chat, you can type those in, and Stephanie will be checking those out for me. We'll answer them at the end. All right, our presentation today, medical professional liability update. I will say this is from a risk management perspective. I am not an attorney. Please do not consider what I say legal advice. I'd also like to add some of the things that we go over today may seem not, on first sight, that may not be applicable to your specialty in emergency med. This may be due to you practicing under your facility's policies and procedures. And to that, I'll say this. I was a nurse administrator, and in every leadership meeting we had, the ED director was always in our meetings, whether they were hired by the facility, whether they came in through a different organization. And I guarantee you, your input into a facility's policy and procedures is immense. You can help mold and shape those procedures. Also, you can create your own procedures and policies for the ED department specifically. To continue with that, we all know the ED is the front door of the hospital, and the administrators need your input. This presentation is accredited for 1 hour of CME and 1 hour of nursing contact. To claim this certificate, you'll go to our website, which is thedoctors.com, or you can go directly to thedoctors.cloud-cme.com. And you will need to enter this activity code 4015 to obtain your certificate. You have until March the 7th to do that. I will say this slide is duplicated at the end. When we finish the presentation and answer questions, I'll leave this up there. That's enough about me. Program objectives today, we want to increase your awareness of top claims categories and mitigation strategies, identify how system and human failure may impact patient safety and increase liability, then also determine what resources and tools can contribute to improvements in patient safety. So why do we talk about medical professional liability claims? Physicians are worried about them, right? This is what keeps us up at night. Something happens during the day, you're worried about it. This is what you're considering. Now, am I going to get sued? I will also say, we'll get into this later, but TDC has a 24/7, 365 hotline, a risk management hotline. You can call us at any time and discuss it. Sometimes it turns into a therapy session. If you're staying up at night, at midnight, want to talk to somebody, give us a call. We always have a risk manager staffing it. Second of all, it's a proxy for patient harm. You can't have a malpractice claim without harm, a breach in the standard of care, and then that casual relationship between the breach and the harm. And then finally, how do we turn malpractice claims into a data source? Here's the short answer. We have specially trained claims analysts who apply a taxonomy to the claim, and then we can compare it across categories. And it works well for presentations like this. Now, TDC is allowing us to pull the curtain back. Between 2012 and 2023, we've had 16,600 claims approximately. These are the top 14 specialties. After 14, the numbers dwindle off, and honestly, the slide's hard to read. But I will say, if you combine OB and GYN like they normally are, they come to 1,171, which would put them in third place. Not place, but the third spot. All right, here's a continued drill down for the emergency med claims. We have 618 total. Of that, 60% are diagnosis related. Again, I drill down for hospitalist claims, 453 total, with approximately 39% being diagnosis related. Recognize a trend. This is injury severity by location for all claims categories. Now I'll read these off. Allow me to read this definition. The insurance industry uses a specific scale to measure harm. That would be low severity, which includes emotional or temporary insignificant harm. Medium severity, which includes temporary minor harm, such as an infection, or permanent minor harm, such as a loss of a digit or non-disabling organ dysfunction. And then high severity includes significant, major, and grave harm or death. Not surprisingly, high severity claims tend to result in higher payments when litigated to a settlement or a decision. Now, if you notice, the ED has a lower total claim count. They have the highest severity percentage. Now, contributing factor is much like the root cause in a root cause analysis. We're going to be talking about two contributing factors today: clinical judgment and communication. And as you see here, each contributing factor can have multiple sub-factors. One second. We disconnected for a second. Talk amongst yourselves.
That would be me.
You're kind of Bill, and he's sitting with his leg right here. And we were like, wrong. Like, yeah, we should have asked Brian. And so on our way out, I'm like, oh, we were there, say hey to them. It's really weird. This lady who we think is with you, and this the man you see, and he comes over. No. We were literally at this whole time.
No, I know.
She probably wonders.
We'll clip that.
Okay, I won't repeat the slide for the recording reason. We got a Zoom issue there. All right, a contributing factor is much like the root cause in a root cause analysis. Now, each contributing factor can have multiple sub-factors, as we see here. And for today's presentation, we will discuss clinical judgment and communication. Now, this 2020 study of serious misdiagnosis-related harms is still relevant today. The authors researched over 10,000 medical malpractice claims, and they identified the 3 most common serious harm categories and the top 5 misdiagnoses in each. They found reducing diagnostic errors by approximately 50% for the 5 most harmful diseases, which include stroke, sepsis, pneumonia, VTE, and lung cancer, could prevent approximately 150,000 cases of serious patient harm per year. So how do we do that? One way is a clinical decision support tool. The integration of AI has advanced this technology by leaps and bounds. And according to healthit.gov, they have seen an increased quality of care and enhanced health outcomes, avoidance of errors and adverse events, and improved efficiency, cost benefit, and provider and patient satisfaction. Now, closed loop tracking, these tried and true methods still need reiteration because in the majority or a good bit of our claims, it comes down to diagnostic imaging tracking and how those results would affect your diagnosis. So the process of identifying, ordering, receiving, and interpreting those results, it's the circle of life. And at any point, you could have a failure in the process. So you'll also need to combat this, you'll need to map the processes, look for bottlenecks, create standardized role-based workflows to make sure nothing is missed or delayed. That's the biggie. We want to identify specific timeframes for following up if they have not been returned in a timely manner. We'll talk about that a little bit further. Technology can assist with this with EMR test tracking module. Now, are you able to either flag or set an alert if a test has not resulted in a certain amount of time? Hopefully you can. Biggie would be stat test or stat imaging. Does that pop up in red that you have a stat study outline? I had a radiologist tell me one time when everything is stat, nothing is stat. Y'all heard that? Everybody's shaking their head. Yes, everybody's heard that. So if you have a facility where everything is stat, okay, that CT might be 3 or 4 hours, right? Here's the biggie. You want to make sure that you're documenting the process. When did you view the test results? Did you authenticate them? Is that a button you click, a dot you fill in that you've authenticated them? But mainly it's your decision-making process. You need that narrative note to say, okay, I've read this, have the radiologist interpretation. This is what I concur and what I'm going to do with that information. When we see claims that involve communication as a contributing factor, it breaks down into 2 different categories. Physician communication with the patients and family. We have poor rapport, that's your bedside manner, misaligned expectations, and then inadequate informed consent. When we have claims around communication between physicians, it breaks down into these sub-factors of communicating the patient condition, and then honestly, failure to read the medical record. This could be shift change, all right? And then between providers, you're looking at, we're handing off to a hospitalist from the ED, that type of communication. Have you ever thought about how you would define a medical record? All right, so I found this very concise definition. I'll read it to you. It's not mine. I should have cited it, so I'm not plagiarizing. The purpose of the medical record is to serve as a chronological history of care, to document medical necessity for billing purposes, to facilitate continuity of care between providers, and to serve as a source of evidence in regulatory investigations and legal actions. Now, that's a lot to cover in a relatively short patient encounter. We talked about poor rapport of the patient. We know that patients who have a strong relationship with their health care team are less likely to pursue litigation in the event of an adverse incident. Now, those relationships can be made or broken in a matter of minutes, and you may only have a few minutes with the patient to begin with. So the patient's perception of you, the staff, and the care provided is likely to color their opinion if they choose to pursue litigation or a medical board complaint, some type of action like that. Angry patients may also escalate their concerns to grievances, third-party payers. I've had to respond to those grievances when I was in the hospital. They're not fun letters to write. And then also, with patient complaints in the ED, what is your system to deal with these? Are you referring to a patient advocate to come see the patient? Are you telling the nurse manager to come talk to them, or do you go and talk to the patient? Just something to think about. Look at your facility's policies. Any of those may work. The main thing is we want to let the patient know they are being heard. Implicit bias in clinical encounters. Every healthcare professional can and will have bad days. Now, hopefully the good days outnumber the bad days, and the bad days are not associated with thoughts or beliefs toward a certain individual or their culture. Allow me to read these definitions. Explicit bias occurs when an individual has a stereotypical and perhaps negative feeling and perception related to a specific group of people. The person is aware of their bias and chooses not to correct the behavior. Explicit bias is prejudice. In contrast, implicit bias is the stereotypes and beliefs that are part of us and affect our decision-making in a subconscious manner. The person who has an implicit bias is not aware of the bias. This graphic highlights the signs of implicit bias in a clinical encounter. All right, So the implicit bias affects our decision-making process in a negative way. And the person to whom the implicit bias is being used toward may see our bullets at the end here: lower referrals, less preferred treatment, poor pain management, delayed follow-up, and often stigmatizing language. So here's the takeaway. Implicit bias increases the risk and likelihood of a diagnostic error. Here's an easy example. People with back pain are narcotic seekers. That's a learned implicit bias that some people may have throughout their career. And we also should speak about cultural competence. This may manifest as either an implicit or explicit bias. All of us come from different backgrounds and tend to see the world from our own perspective. Just have a self-reflection and understand if you may have a deficit in your cultural competence. All right, informed consent, it partially mitigates a known risk when performed well. Now, this does not have to be a form, informed consent documents just make it easier, you don't have to remember everything. But really an all-inclusive narrative note might be even better, because the malpractice claim won't come a week from now, it may come a year from now. And that narrative note may actually cue you to who this patient was in the situation, where a form will only have 2 signatures on it. We see this: a general consent to treat may not cover everything. Consent to treat will get them in the door, but an invasive procedure may need an additional informed consent, or at least that discussion. Now, on our hotline, we get questioned a lot is, what is an invasive procedure? When do I need to use informed consent? We can't determine that. As a med mal carrier, as a risk manager, we won't tell you how to practice medicine. We don't tell organizations how to run their office. So that would be up to you. If it's a laceration that you're suturing, that may result in a large, disfiguring scar. You might want to inform consent. You might want to document that discussion that, hey, this is a risk. If you don't want me to do it, we can schedule a plastic surgeon to look at it, something of that nature. Now, failure to conduct an adequate informed consent harms, remember, you got to have harm in a med mal claim. It harms the patient. They may not understand what they're agreeing to, and they may not have agreed to it if they'd known and understood the risks. And this also erodes the trust. We talk about that healthcare patient-physician relationship. That is going to erode this trust. Now, there's no need to reinvent the wheel. Excuse me. If you are in those leadership meetings and they want to talk about informed consents, TDC has lots of sample documents. This is just a few of them. I was also mentioned the website has over 100 online courses for CME, nursing contact hours, and also closed claim studies, articles, lots of information out there. All right, informed refusal. The informed refusal conversation is much like the informed consent. You describe the RBAs, the risk, benefits, and alternatives of the procedure. The patient accepts the risk and then signs the document. If they refuse to sign the document, you can sign it, date it, put it in the medical record, patient refused, and then have a narrative note about the conversation. Again, it doesn't have to be a document. You can have a verbal conversation with them as long as all inclusively noted. Now, in the hospital setting, this is likely an AMA. When I was a floor nurse, I was cardiac step down, and a patient wanted to leave AMA. I said, okay, let me notify your physician. Here's a document to sign. And then one of 2 things happened. Either the doctor said, all right, let them go. Or they said, hold on a second, try to keep them. I'll be by within an hour. That's what we're looking for. If a patient wants to leave AMA, at least have that conversation with them, that one-on-one, so that they really understand from you what's going to happen if they leave, or at least the risk of leaving. All right, when it comes to a diagnosis, all of our information, a lot of it, I'll say at least, comes from the patient. What's going on? What happened? What's your medical history? Well, when we get to a claim and the defense attorneys start asking physicians, they say, well, the patient didn't tell them. All right, we get that. So here are some of the reasons why a patient may withhold information. As physicians, you probably have your comfortable patterns of patient interaction. Do the same thing every time you come in. However, the inclusion of just one of these tips may help expand that. One of the things that we hear is physician came in, looked at the computer, glanced at me for 3 seconds and was gone. All right? How can we improve that? This one bullet point here, introductions, eye contacts, listening strategies. If that is something that you're lacking, it could definitely help with that patient interaction. Inappropriate behavior, have you encountered that in ED? Likely. It's helpful to establish these expectations early in the patient-physician relationship. This can be a number of ways. Patient behavior agreements with the admission paperwork. You could have signage. We do encourage the signage that whatever you choose to do, stick to it. We want to nip it in the bud early. If you have a family member that is not meeting that behavior agreement, and you say, okay, if it happens one more time, we're about to call security to escort you out of the ED, call security. All right, if it does happen one more time, you don't want to keep letting it escalate. Signage, we do suggest that. Any type of verbiage may work. I would say, depending on your state, what they will allow will definitely shape this. Personally, my dermatologist has a 3 by 4 foot sign outside of the office and inside the lobby with a giant red hand. It says stop, read. And their behavior agreement is written, and it also goes into the statute that allows them to prosecute if it's ever violated. That's for Alabama. All right, receiving direct patient feedback. This can either be in person at the bedside, or likely your organization or facility will be obtaining these patient surveys upon discharge. These are good. We want to look at our feedback. I encourage ED staff to get these, go over it with those around you, not just in your organization, but also the nursing staff. And we want to know what we're doing well. We also want to know where we're lacking, where we can improve. Here's the biggie. Again, I'm going to reiterate, don't ignore the patient. We want to acknowledge their concerns and let them know that we're listening and that we hear what they're saying, and we're going to check on it. Countless cases or some type of medical board complaint came from the patient saying, I felt like suing the doctor was the only way I could get them to hear me. Countless cases. The patient just wants to be heard. And if you take the time, go through these patient feedback results, that might be the determination between a regulatory action or just listening to the patient and understanding their complaint. All right, this adverse incident definition is for Georgia. I'll let you read it for yourself. Each state, a majority of states, will likely have some type of wording that defines an adverse incident. And when we talk about disclosure from an adverse incident, how do we disclose? You're welcome to read through these. Here's the main thing. Be a human. What would you want to hear? If it was your mom, dad, relative, and you were in a position where there was an adverse event, what would put you at ease? The hospital risk manager will likely sit in on this conversation. I've had to do it. Not the favorite part of my job, but it does happen. Be careful if the patient starts asking, are you going to fire this individual? What kind of action is going to be taken against this individual? That's all HR concerns are confidential. You can't get into that. Just let them know that you are investigating. And then before acknowledging any responsibility or even offering a refund, some type of reimbursement, call us. Let us guide you through that process. All right, how to document the disclosure. This is like any type of encounter, any type of communication. Be objective. Document what was discussed, what questions were asked, who were present. And down here, we use the term buff and puff. If you're going to alter the record, do it in an appropriate way. Late note, an addendum, something like that. It's a lot easier to defend a medical record that's actually lacking documentation than it is to defend one that's been altered. Again, I'll let you read this for yourself. This is for Georgia, but majority of states do have a definition around this, expressions of sympathy. Take note of the shall be and shall not. Now, disclosure and apology usually go hand in hand, and individuals need an apology or expect an apology when this type of event occurs. It's okay to say, I'm sorry this is happening to you. It's okay to visit the patient if they're admitted to the hospital. It's even okay to send a get well card. None of that, according to this, I'm not an attorney, should be considered an admission of guilt. And we'll get into the resources that TDC offers. Looking at number 2, virtual record reviews. We do this a good bit. This just provides confirmation of what you're doing well. And also, we can identify some areas of improvement. Lots of physicians take us up on this. Resources, we've discussed sample documents, the free CME, articles and closed claim studies. And then we're just another set of eyes and ears. Call us, let us hear what's going on. Obviously, this with the ED setting, this may be after the fact, but any type of insight could help on the next encounter. Going back to the risk management phone line, some of the things we hear, the main one here that I want to talk about is number 3, notice of a first report. This is called, we call this an NFR. If you call in, we're going to say, let's submit an NFR. This can be for anything. Upset patient, unexpected outcome, a subpoena, or a medical board investigation. This is a proactive way to let your insurance carrier know that something has occurred. You will be assigned a file number. If nothing happens, perfect. If something does happen, even a medical record request off of this incident, call us back with that file number or email us back with that file number, and we can update it as we go through the process.
And I would add to that, that does not negatively affect, your claim history or, your premium, your future premiums going forward. So, if you guys are afraid that, gosh, if I turn this claim in or this possible claim, then, we're going to be adversely affected from a premium standpoint or underwriting. That's not the case. We would much rather have these first reports as soon as they happen. If you guys have any concern about the medicine, go ahead, turn it in. Let's set up a file. And then if it ever turns into anything, we've got that set up.
I'll echo that. We're on the same team. We want to hear about this stuff early. Again, medical board investigations. If this happens to you, let us know. There's possibly coverage that will assist in creating that draft document to respond. I'm going to stop here on number 7, the Cures Act in the open notes section. I'm sure that majority of you have heard of this, and you should act like the patient is standing over your shoulder. Here's the one thing that falls to the wayside with this, the interoffice notes. Does anybody work in Epic? Does your version have that yellow sticky pad? Okay, those are interoffice notes. Now, if you don't have that, it's a yellow square, like a yellow sticky pad, and nursing staff will type something in there, or physician to physician, and this information is fluid. Like I would type, Dr. Smith, please contact room 2713 sister with an update the next time you round. So when Dr. Smith, he's going to document that telephone encounter with the sister. And then as I see Dr. Smith, I'm gonna say, hey, did you call the sister? Yes, I did. And I updated her. Well, what I'm going to do is I'm going to go in there and erase that, because these are fluid notes. These are back and forths. Those are discoverable. And I think because they're not, you don't actually go to the medical records section and type it in, that individuals think those aren't discoverable. They are. So that metadata, the time, date stamp of all that is actually, you can find that. So be mindful of that. I've got a couple of examples that are just like, why would you ever type that type of example? And to summarize, why do we talk about claims, patient safety, and risk management? Here's the reason: to mitigate high indemnity malpractice claims. Take a second to review this slide. we hear more and more about nuclear verdicts. And Georgia is no exception, as you probably know. In fact, $10 million verdicts are not even newsworthy anymore. You need 50, 75, triple digits in the millions to hear about it on the news. All right, that's the end of our presentation. I will go back to our CME directions. If you need anything from me, my email is just first initial, last name. That's Kleckler with 2 L's. Second L gets left off a lot. At thedoctorswithans.com. And there's our CME information.
Eric, can the CME certificates for our providers just be sent to us and then we can put them in their file and send them out to them?
Absolutely.
Okay. We can, Julie, okay.
Now, oh, you're saying the names come to you?
Yeah, can we just get this, so they don't have to do it individually, because we need it for our files anyway, because we keep up with their CME.
Possibly.
Okay.
We'll discuss it.
You also sort the CME specialty courses or courses by specialty?
When you create an account, I believe it asks you just physician, nurse, or you get a participation certificate if you're not clinical. I'm not certain. We have a continuing professional education team that handles those. I know there is a way that you can type in an organization and possibly we can search by organization.
Can, we get connected to those, Julie and I get connected to that team,
Yes.
so that we can, because does anyone here know how to go to the TDC website currently and do CMEs online? Yeah. So just so we can send it out to them, like maybe come up with like a template on what they have to enter in order to, do they have to have their policy number, those kind of things to gain access and get those free CMEs.
Sure. We have a PDF. I've sent it to Dr. Williams, but yes, give me your email. I'll send it to you.
Okay. Julie, anything else?
Any questions online?
I don't see, hold on, let me just double check. I didn't see any right before you. I sent a test, but I only saw my test. No. Does anyone have any questions here?
And I will also add, in addition to Eric, we also have resources so that, if you guys have any questions from a claim standpoint, could this turn into a claim, we're an additional resource on the broker side to reach out to. We have a former claims adjuster and an attorney on staff that can help kind of walk you through next steps when you have a bad outcome or possible bad outcome. So, you've got numerous resources, so please don't hesitate to reach out. It's not gonna, harm the company, harm you guys. It's in your best interest to let everyone know as early as possible.
Thank you.